So our next speaker is Dr. Bruce Montgomery, who people confuse as my twin because we do have a lot of similarities there, but he'll be focusing on clinical trials, some new agents and new combinations in advanced prostate cancer.
Good afternoon. Hard to follow Dr. Mostigal, as she always has a very impressive presentation, but my job this afternoon is to talk to you a little bit about where we're going in terms of clinical studies, why we've chosen this path, and why I think most of us are incredibly optimistic about the future in treating men with prostate cancer. So I think it's important, thinking about where we're going, to look back at where we were. So in 2004, this is a schematic of basically what we had in terms of options for therapy. So men got local therapy, surgery or radiation, and if that was not curative, PSA would rise, we'd give hormonal therapy. Cancer would then enter this phase which was called hormone refractory. It was not something that could be addressed with any other hormonal therapies, and we really went on to, in many cases, not very effective subsequent treatments. So this is where we are today. So we've now, as a result of the work that Dr. Mostigal presented, understood that, in fact, these cancers are not refractory to hormonal manipulation. They, in fact, are resistant to our standard treatments, but, in fact, with more effective therapies, we can really suppress growth and hopefully, as I'm going to show you some data about, at some point or another, hopefully be able to rid the body of prostate cancer if we can optimally suppress androgen receptor signaling. We now have these drugs, abiraterone or Zytiga. You heard a little bit about that from Dr. Mostigal. This is the way that we can best suppress hormonal signaling in prostate cancer. You heard from Dr. Hagano about Provenge. Again, definitely a step forward in terms of improving outcomes for men. We now have chemotherapy, and then these drugs are also, including enzalutamide, a better hormonal therapy, are effective after chemotherapy. So between 2004 and now, we've gained all of these medications in the treatment of prostate cancer. And it's important, I think, to emphasize that I'm going to talk about clinical research, and the only way we got to this point is by doing studies looking at how new therapies might be more effective than what we do already. So when I talk about clinical studies, we're talking about research, okay? And that is a word that a lot of people find a little bit difficult to put together with what they're going through. Most of what I'm going to talk about here is looking at whether a new therapy, a new agent, may be more effective than an old one. Now, there are multiple steps along that path. So there's something called a phase 1 study, which is the first time a drug has been given to somebody, ever. In this case, we're going to be talking about prostate cancer. And the idea is to show that it's safe and that we can give that drug at the right dose at the next step forward. A phase 2 study is when we're seeing how effective it is, just using that treatment alone and measuring things like PSA, changes in bone scans. And then phase 3, if these drugs look very effective, we take them forward and compare them to what is considered the standard of care, or sometimes against other therapeutic interventions if there is no standard of care. I'm not going to talk really about phase 4, which is really what we do after the drug comes into the clinic. So I think you've heard from the two previous speakers that recently the major steps forward have come from two areas of research. So one is this idea that, in fact, hormonal regulation of prostate cancer is an important point of inflection from the very development of the disease all the way through the treatment course. And as a result, we have Zytiga and enzalutamide, and now we have, what I'm going to show you in the next few minutes, a whole slew of other drugs that we think are potential improvements on what we have in the clinic today. It's worthwhile emphasizing that the group here has had a lot to do with understanding why these drugs work and choosing how to go forward with new treatments. Likewise, immunotherapy, you heard from Dr. Hagano. There are all sorts of new things in the pipeline. Again, worthwhile emphasizing that the group here played a very important role in development of these therapeutic options. So what I'm going to talk about in terms of what we're doing today is trying to take advantage of what we already know and what we know works, meaning hormonal therapy that provides survival and quality of life advantages for folks, as well as what I'm going to talk about in a few minutes, trying to find the new drivers in prostate cancer, because the step forward will be finding new things that we can target in addition to what we already know about. So a lot of our emphasis is on hormonal therapy. So what we're doing in research is we're moving those therapies much earlier in the course of treatment. So for example, we have studies here in which men who are getting surgery or radiation therapy are getting these systemic therapies at the same time, with the idea that we can treat cancer anywhere, optimally treat the cancer in the prostate and treat anything that might have gotten out before the diagnosis was made. We're trying to optimally use abiraterone with other agents, and then we're choosing other agents that have new bells and whistles, potential improvements on what we already have in hand. I'm going to talk about these for just a few minutes. So one of my areas of focus is in trying to improve outcomes for men who are just getting their first therapy for prostate cancer. So for men who have higher than average risk cancer, high Gleason grade, high PSA, oftentimes what we do is use hormonal therapy with radiation because that improves outcomes. So you heard from Dr. Mostigal about abiraterone, which is basically our best hormonal therapy. And so we have an open study in which everybody who enters gets abiraterone for 3 months before radiation and with radiation, with the idea that we're, again, optimally suppressing cancer, potentially killing cancer, both in and outside of the prostate. This is a study that, when I wrote this talk, actually the study was still open. We've actually accrued patients very quickly, and this is a study that just closed, but it's worth talking about because it's a model for what we're going to be doing going forward. So in men who have, again, localized prostate cancer, higher than average risk of having it become a problem down the road, men were treated with enzalutamide, this maximal blocker of androgen receptor activation, either alone or with hormonal therapy. Part of the reason for doing this study was to see whether we even needed other hormonal therapies, because if this drug was as effective as we think it might be, it may not be necessary to use other drugs to optimally suppress and treat prostate cancer. So men in this study had 6 months of either one of those approaches, enzalutamide alone or with other treatments, and then have a prostatectomy. Now this study is still in process. Many of the men are still being treated, but our last set of studies, again, which were driven by Dr. Mostigal and other members of the group, in which we used abiraterone with surgery or other combinations of hormonal therapy with surgery, found that about a third of men who had, many of them with very high Gleason score cancers, for example, had little to no cancer in the gland when the surgery was done. So our interpretation of that is that there are patients whose cancers are very susceptible to this, and we have the potential for completely eliminating that cancer with these hormonal manipulations. And so we're continuing to add these drugs in new combinations prior to surgery and radiation to improve outcomes for folks. Trying to improve on what we already have. Abiraterone is our best hormonal therapy that we have in hand right now. There's a study that is just getting started here at the university and is open at a number of other institutions nationally, in which we use something called a PARP inhibitor. So in prostate cancer and many other cancers, the ability to repair DNA damage to the chromosomes is impaired. And the idea is that that impairment is specific to the cancer. If you can completely block the ability of the cancer to repair DNA damage, the cancer may essentially just die. And there are a lot of reasons why we think that putting better hormonal therapy with this inhibitor might make more sense. And so there's a study that is just getting started in which we are looking at really the genetics of the specific cancers and then looking at whether the addition of PARP inhibitors may actually provide better outcomes for people. Again, really looking at this on a molecular level and trying to personalize the treatment. As an example of many drugs that are already in studies, and I'm not going to cover all of them, essentially everybody that you've heard speak has a number of these studies open. One of the drugs is galeterone. Sounds a lot like abiraterone for a good reason. It's essentially the same drug with a couple of bells and whistles added. The whole idea here is that it does block the androgen receptor, blocks hormone synthesis, and may make the androgen receptor go away entirely. So the first study we participated in, this is looking at decreases in PSA in patients with advanced prostate cancer. Many of those patients had very nice declines in their PSA. And the reasons for all these colors were to show you that as the dose went up, the responses basically increased. And so we're now moving on to what's called Armour 2, which is a study really specifically looking at whether this drug will work better than abiraterone by looking at folks whose cancer is becoming resistant to abiraterone. So we think this is a way of maximally dealing with hormonal activation in these prostate cancers and sort of moving on from what we already know. Now, I think Dr. Pritchard and perhaps Dr. Nelson will talk about this some more, but we are also looking at how to best define what is driving this other than hormone therapy, right? I mean, I've been harping on that, but the idea is that we haven't found a really effective point of inflection for treatment of prostate cancer because we probably didn't really understand what was going on in terms of mutations. It's very hard to get metastatic prostate cancer, and so the idea here is to look at the genomics, figure out what is driving these prostate cancers by actually sampling metastatic disease, doing what's called whole genome sequencing, something that used to take, it's hard for me to really estimate how long. It took years in some cases to do all the genes in these cancers. Because of the improvements in technology, we can now sequence all the genes in a cancer and in the normal genome in a month. And so we are a part of a consortium, they call it the Stanford Cancer Dream Team, in which patients have the option, and many patients who are in our other clinical studies that involve getting biopsies are being involved in this study where we find out what all the mutations are, what all the changes are molecularly that may allow us to move forward with drugs that we actually don't use in prostate cancer right now, but have the potential to be very effective. So this is obviously sort of looking forward, trying to improve our ability to define where the next steps are. We already actually know from work that has already been done that other areas may be very effective in terms of targets. So something called the PI3 kinase pathway. I'm not going to talk about this in a lot of detail, but there are drugs that can target this pathway, and there's a lot of data that says even in response to abiraterone, cancers may become resistant by activating this pathway. So there's a study that's just getting started putting both our maximal inhibitors of androgen signaling, enzalutamide, together with this inhibitor of PI3 kinase inhibitors. And then a second drug, which is targeting a different driver for prostate cancer, something called cabozantinib, has shown really fairly dramatic effects in early stage studies. And there are studies opening right now in multiple stages of disease where patients are given the drug, and then we also look at things like what is going on in the bone to better understand the biology and how we can improve on cabozantinib, which I think many of us believe will be something that will be FDA approved in the future. So this is trying to give you an overview of where we have studies going on. So we have moved these drugs that you heard about into very early stage disease. We now have this sequencing process where we can basically look at all the genes activated in a prostate cancer. We're doing studies really understanding why some cancers are sensitive and resistant. There are a number of patients who actually I've seen here who have very generously been involved in the study where we actually look at what's going on in the cancer itself in terms of hormone levels, in the context of giving abiraterone. And then all these other drugs, again, we're trying this everywhere with all the most effective drugs that we have available. So I think we have a lot of hope that all of these things will in fact be effective, with the idea that if we maximally suppress androgen receptor signaling, we are hopeful that that will eliminate prostate cancer, and if it doesn't, we will know why, so that these other points of inflection will in fact change things. So, and I think, again, I want to reemphasize this whole issue because finding what is driving cancer that we don't know about is the next step in the future of treating this disease. So this is what we want to happen in our lifetimes. We'd like to prevent every prostate cancer. We'd like local therapy to cure every prostate cancer, and if we can't do that, we find the therapies that can eliminate it if it comes back. So I don't know if I was under time because I wasn't looking at Amanda, but thank you.